off. Hello and welcome everyone to this month Fireside Chat in recognition of Cervical Cancer Awareness Month and Human Papillomavirus, also known as HPV Prevention Week. So the Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. The Office of Community Outreach and Engagement serves as a bridge between the Cancer Center and communities across the state of Minnesota. Our team's mission is really to reduce the burden of cancer in Minnesota by engaging communities and providing them access to knowledge and information on the latest cancer research, cancer prevention, the importance of screening and early detection, treatment options, survivorship, as well as clinical research opportunities. My name is Amna Hussein. I am the Community Engagement Coordinator on our team, and on behalf of our team, thank you all so much for joining us today to help us raise awareness about cervical cancer and HPV infection prevention. So as you already know, January is Cervical Cancer Awareness Month. So this is the time to talk about preventing, detecting, and treating cervical cancer. We have all the tools we need to effectively prevent cervical cancer. And so today we will be hearing from two incredible experts working hard to make a cervical cancer-free future possible. So here is our speakers today, Dr. Deanna Teoh and Dr. Rebekah Pratt. Dr. Teoh is a gynecologic oncologist dedicated to preventing cervical cancer and other HPV-associated cancers. She received her medical degree from the Medical College of Wisconsin. She completed her residency training in OBGYN at the University of California in San Francisco, and then subsequently completed a subspecialty fellowship in gynecology oncology at Duke University. Clinically, Dr. Teoh specializes in the management of gynecologic cancers and has a special interest in minimally invasive surgery. Dr. Teoh has also has several research interests in this field with a focus on improving surgical outcomes, optimizing cervical cancer screening, and increasing HPV vaccination, and increasing healthcare communication with the public through social media. Her expertise has led to invitations to serve on several national research and education committees. Today, Dr. Teoh will cover the clinical aspect of cervical cancer, in addition to briefly discussing her research and optimization of cervical cancer screening and prevention and increasing HPV vaccination uptake. Next, I would like to introduce our second speaker, Dr. Rebekah Pratt, who you probably noticed her photo on our Community Outreach and Engagement team. On our team, she serves as the co-associate director with a focus to support our ongoing efforts to build relationships with communities, enhancing community engagement, and bringing community voices into our work. Dr. Pratt is also an associate professor in the Departments of Family Medicine and Community Health and the Program of Health Disparities Research. She is trained as a community psychologist in New Zealand. She obtained her PhD in population health science at the University of Edinburgh in Scotland. Her work focuses on addressing disparities in cancer prevention, such as screening and community engaged research. She focuses much of her work on immigrant and refugee health. Currently, her research is focused on an HPV self-sampling method to address the low rates of cervical cancer screening among American Somali women in Minnesota. You'll hear a bit more about her research during her talk. So as you just heard, we are just incredibly grateful to have these two experts joining us today. So we will be recording today's session as we do with all of the Fireside Chats so that you can always refer back to the recordings on the Masonic Cancer Center's YouTube page. Before I begin, I would like our audience to get familiar with using the Q&A feature, which is located on the bottom of your Zoom window. During today's presentation, please use the Q&A feature to submit your comments and questions. Drs. Teoh and Pratt will be available to answer live questions during our program today following their presentations. And so without further ado, I will now hand it over to Dr. Teoh.
Thank you for that very kind introduction, and to the Masonic Cancer Center and Dr. Pratt for inviting me to join you today, and especially for spending this time to really highlight cervical cancer, other HPV associated cancers, and what we can do to prevent them. As a gynecologic oncologist, I still see a lot of cervix cancer and then lower genital tract cancer. So vaginal vulva is what we deal with in gyn-onc. And there is the possibility of a future in which we don't see these cancers. And so we'd really like to get there eventually. So I am going to talk briefly in this presentation about my research, which has always circled around, cervical cancer and HPV associated cancer prevention, but more recently has really focused on high risk populations. And then I know some questions have been submitted prior to this presentation. And I'm hoping that we'll be able to generate some discussion and make sure that everybody gets their questions answered. So I have no disclosures that are related to this topic at all. So the high-risk populations that I am currently focusing on are survivors of childhood cancer, individuals with Fanconi anemia, and then solid organ transplant recipients. And I think one of the things that I've been very lucky with at the University of Minnesota is that these are actually all areas in which we have experts at the University of Minnesota. And so I think, for those of you who are providers in the community or within Fairview, you see a lot of these patients just because they come here, for their care. And I think, for the community, to recognize that, there are a lot of people, most people will be at average, so there are people who are at even higher risk, and maybe we need to even more do more screening or, better job of getting people vaccinated to try to prevent these HPV associated cancers. So the first population I'm going to talk a little bit about are childhood cancer survivors. So the good news is that our treatments for childhood cancers are improving every year. And in fact, 2015, which is the last year that I could find really good estimates, there were 429,000 survivors across the United States of childhood cancer. So that's amazing. I think it's devastating when we hear of a child who's diagnosed with cancer, but the reality is that a lot of these patients are actually doing really well and living into adulthood. Now, the problem is both because of these cancers and especially some of the treatments that they receive for these cancers, they can have a lot of other secondary problems. And so one of the things you can see are secondary cancers are actually one of the highest causes of death when these patients have gone into long-term remission, from their original cancer. Childhood cancer survivors specifically are almost 3 times more likely to develop HPV-associated malignancies. And the average age at diagnosis is much younger than we see in the general population. So in general, we say the average age is somewhere between probably 44 and 54 with an average age of 50. Whereas a lot of times we're seeing these cancers in childhood cancer survivors somewhere between 27 and 38, depending on which study you look at. So this table just shows you the standardized incidence rate. So how many times higher is a childhood cancer survivor's risk of any of these cancers compared to the general population? And I think one thing we always think about with HPV is cervix cancer, but you can see here that the risk is pretty similar to the general population, and we'll talk about why that is in a minute. But I think when you look at males, because again, when we think of cervix cancer, we don't necessarily think of males, you can see that anal cancer is almost 3 times higher than the general population. And what I didn't circle here, but down in the head and neck cancers, their risk is 2 to 3 times higher than the general population. And given that we are seeing an increase in head and neck cancer in general in the United States, this number is probably going to escalate even more. Now, the reason that we see some of these other HPV-associated cancers more so than we see cervix cancer is because cervix cancer, although this slide might be a little bit outdated at this point, is the only one that we have a really good screening test for. And in fact, if you look at cervical carcinoma in situ, so that is the precursor to an invasive cancer, that is the most common, quote unquote, cancer or solid tumor that you'll see in childhood cancer survivors, and especially those that have undergone stem cell transplant. And we see a lot of those people here at the University of Minnesota because we are actually one of the leading centers nationwide for stem cell transplant. So a lot of these patients will either come and will live in the area, or they'll come just for specialized care and sometimes receive more than just their oncologic care here. Their risks of an abnormal Pap test are 7 times higher than the general population, and their risk of precancerous changes of the cervix or cervical dysplasia is up to 50%, especially after stem cell transplant. And then those kids who have, or young adults who have both a stem cell transplant and then develop graft versus host disease, so where we have replaced their bone marrow, but their body is kind of fighting it, they're at the highest risk for abnormal cervical cancer screening. So I think one thing to point out is that for childhood cancer survivors, they actually fall into a high-risk population. So the NCCN guidelines, or the National Comprehensive Cancer Network guidelines for childhood cancer survivors, is that these kids receive 3 doses of the HPV vaccine regardless of age. So the general recommendation is that if an adolescent is under the age of 15 when they start, they can get by with 2 doses. And if they're 15 or older, they need 3 doses. But because these patients might be at higher risk just because of the immunosuppression associated with their cancer treatment, even if they are 12 years old at the time of vaccination, 3 doses is still recommended. And they can get vaccinated as early as 6 months after their treatment. Those who have been vaccinated prior to their cancer treatment do not need to be revaccinated unless they had a stem cell transplant. Those adolescents do need to be revaccinated, or if they're vaccinated in the middle of their cancer treatment. So I think for those, anybody who's joining who's a primary care provider, or if you are a childhood cancer survivor or the parent or guardian of one, just something to keep in mind, because I find that this is not something that is widely known. So unfortunately, even though survivors of childhood cancer are more likely to get HPV-associated cancers, what a lot of studies have shown is that actually cancer survivors are 2 to 4 times more likely to be unvaccinated, with HPV vaccination coverage of only about 40%. Not surprisingly, similar to national averages, females do tend to be more vaccinated than males. And I think the other important thing is that, this 22 to 39% who are vaccinated, a lot of them have only received 1 dose, and only about 60% received 2 or more doses. So that's one of the things that we're trying to improve here. So we actually have funding from the Department of Defense to increase HPV vaccination initiation and completion among childhood cancer survivors. And so the first thing we did is just a quality improvement intervention. So we know from the general population that actually healthcare providers are some of the people who can move the needle the most as far as getting people vaccinated. And what we realized when we talked with the leaders of our cancer survivorship clinics is that they would recommend all these different tests for these, other high risk conditions that these survivors are at risk for, but they weren't necessarily recommending the HPV vaccine. And part of it just wasn't something they were thinking about, because they're thinking about 10 other things that these survivors need. And so part of it was just giving that, education to the staff. And that's anything from the schedulers to the rooming staff to the nurses, the nurse practitioners, as well as the MD providers. And then the second thing that we're looking at that we're rolling out, hopefully in the next month, is a randomized controlled clinical trial. So what we're actually looking at is a patient intervention where we're actually giving them a game-based learning app. So they get to make a cute little avatar, they get to do some education. This prototype here is actually for cervical cancer screening, but we're actually reprogramming it to look at HPV vaccination. And then also reminders so that they can program when they got their first vaccine, and they can get a text message reminder reminding them, okay, you're due for dose 2, dose 3, because as we all know, we get busy, we forget to schedule these things. So we're looking at that versus just the healthcare provider recommendation alone to see if we can improve these HPV vaccination rates. So that's one study that we currently have ongoing, and hopefully we'll find that it's successful. So the other population that I'm interested in is those patients with Fanconi anemia. So Fanconi anemia is actually a rare condition, and it's a DNA repair mechanism defect. So, our cells are dividing all the time. We're replicating our DNA. And as you can imagine, if your cells are turning over and over and over, sometimes there are mistakes made, and usually our cells repair it. And so we can go on functioning just fine. But for people with Fanconi anemia, that does not work as well. And so they can have a lot of different sequelae from that. And so what I'm interested in, obviously, is cervix and lower genital tract cancers. And interestingly, these individuals are at 500 to 3,000 times increased risk of vulvar cancer, which is an HPV-associated cancer generally that we do not have a screening test for, and 100 times increased risk of cervical cancer, as well as head and neck cancer. So these are, in general, considered HPV-associated cancers, although the interesting thing is we're not sure that HPV is actually required for people with Fanconi anemia. Similar to our childhood cancer survivors, the average age of diagnosis is also much younger. So again, we're seeing these cancers at around age 25. So I will say that because a lot of these people, who are in the Fanconi anemia clinic get a lot of their care here. And I will say that the University of Minnesota has one of the most comprehensive follow-up programs where routinely what will happen is people from out of state will come for 3 days, and they will get all the surveillance that they need after they've had their treatment for Fanconi anemia to look for all the secondary cancers and other problems. So it's, dentistry, it's GI, it's gyn-onc. and we screen, all of these, young adults and sometimes adolescents, depending on, where they are in their course, for these cancers. And I will say that that program does a very good job at recommending HPV vaccination starting at the age of 9. But again, we don't really know what the efficacy of that is because it's questionable whether patients with Fanconi anemia really need HPV to drive their cancer. So one of the things we want to look at is what is the clinical efficacy of the HPV vaccination to prevent these cancers, specifically in the patients with Fanconi anemia. And then we wanted to look at the adherence to and efficacy of anogenital cancer screening. So for these patients, screening is actually recommended starting at age 13, so extremely young just because they are at such high risk. And annual screening. So even though we in general will recommend cervical cancer screening every 3 to 5 years, depending on the patient's age and what tests are being done, for these young people, we're actually recommending it every single year. And so we don't really know, how efficacious theirs is. We don't really know, do we have that lead time from, a precancerous lesion to cancer, or does it progress so quickly that they're just going to develop cancer anyway? And then are there other biomarkers, so other tests that we can do if we do a biopsy to identify who's at risk for cancer and who isn't? So this is actually something that we applied to the foundation, the Fanconi Anemia Research Foundation for funding. And this is actually being rolled into a greater NIH project where they're going to look at all of these things for head and neck cancers as well as cervical and anogenital cancers. So hopefully the University of Minnesota will be a leader in this as well. And then the last population that I'm interested in is solid organ transplant. So again, what I realized as I started looking into this is that the University of Minnesota is one of the leaders in solid organ transplant. And this has been a huge advance for people with end organ disease. You replace their kidney or their lung or their heart, and they can live for a number of years longer. Now, the problem is that once we give a new, body part to someone or a new organ, that we have to actually suppress their immune system so that their body does not reject that organ. And the problem is that when we do immunosuppress people, we potentially allow HPV to, sit in their body unchecked. And so what we know is that patients who have had a solid organ transplant are at 2 times higher risk of cervical cancers and 3 times higher risk of carcinoma in situ. So again, the good news for cervical cancer is we actually have a screening test. So a lot of times we can diagnose it at the precancerous stage, treat it, and actually prevent the cancer. And then vulvar and vaginal cancers, their risk is increased more than 20%. Now, I know that number looks really high. I will tell you that, in general, these are rare cancers. So you take a number that's low and multiply it by 22, it's still pretty rare, but these people are at much higher risk. And again, we don't have great screening tests. We do have ways that we can, diagnose these in the precancerous stage and, treat them and hopefully prevent the cancer. But we don't have a true screening test where we can do, something like a PAP and HPV test like we do for the cervix and find lesions before they're even apparent to the naked eye. Now, one of the things I found interesting is that the risk varies by the type of transplant. So a lot of the data we have are based on kidney transplants. That's the most common transplant. And the risk, if you've had a renal or a kidney transplant or a liver transplant, is about 2 to 3 times that of the general population. But for those patients who have had a heart or lung transplant, that risk is almost 8 times increased. And part of this is those who have a heart or lung transplant need a higher level of immunosuppression. So again, they have very little immune system compared to even those who've had a kidney or liver transplant. So one of the things is that most post-transplant cervical cancers are actually caused by HPV infection prior to transplant. And so where this study came from is actually the transplant surgeons and the transplant medicine team asking me, what do we do with these patients who, part of their checklist is to screen for cervical cancer, and maybe they don't have cancer. In fact, hopefully they don't have cancer at the time that we're seeing them, but maybe their screening tests come back abnormal, which does suggest they may be at increased risk. How do we manage these patients? What can we do? How often do we rescreen them, especially because some of these patients are going to be on the transplant list for a couple of years. And then for some of these patients, they will suddenly get a transplant. You don't always know when that transplant's available until that organ is available. So if you look at the guidelines for solid organ transplant, basically prior to screening, the recommendations are pretty vague, basically saying up-to-date age and sex-appropriate cancer screening, again, with no guidance for when to rescreen while on the transplant list. So we get a lot of these patients that are referred to our clinic and they want us to do a PAP and HPV test, so they can get on the list. But then when they're on the list for 5 years, how often do you rescreen them? And I will say a number of these patients are immunosuppressed even prior to their transplant because of their underlying disease or because of dialysis, even if they've got kidney failure. And again, when we're screening these patients, The goal is really to rule out an existing cancer, because unfortunately that is something that makes patients ineligible to get on the list. And I think what's interesting is most of the guidelines we have are based on just Pap tests. So that's where we look at the cells from the cervix and it tells us what's going on right now. If there's abnormalities in the Pap test, then we're suspicious that there's something going on right now in the cervix. More recently, we've added HPV testing. So that tells us not only what's going on now potentially, but what could happen in the future. So if somebody has a high-risk HPV test, while it doesn't tell us for sure that there's something going on right now, we do know that they're potentially at higher risk for developing either precancer or cancer in the future. And especially if we then suppress their immune system after they've already been infected with HPV. So the biggest problem is when you really look into this, the data are lacking to make recommendations for pre-transplant cervical cancer screening and management. And so because we have such a large transplant service here, we actually just put in a proposal for RO3 funding, and we did receive approval to get some funding, at least from here, while we're waiting to hear on that NIH grant, just to review our data here at the University of Minnesota and to start coming up with some hypotheses and maybe even some basic guidelines that we can test so that we can make sure that we're optimizing cancer prevention at the same time that we are trying to cure these people of their end organ disease by giving them an organ transplant. So the first thing we wanted to do is just look at what is even being done, prior to pre-transplant. How are we managing them? What are we doing when these patients do have, precancerous changes or HPV positive tests? How many are being vaccinated prior to their transplant, which is actually the ideal situation? And then to look at post-cervical dysplasia risk, after transplant based on their testing prior to transplant. So can we predict or can we know who's really at the highest risk? And maybe we have to be a little bit more aggressive than the general guidelines for the average risk population would suggest, so that we can safely transplant these patients, but not significantly increase their risk of cervical or lower genital tract cancers. So this is just kind of a schema of what we propose. So we're really in these beginning steps here just to even look at the data that are available. Our hope is, and we've been talking with some other institutions with large transplant programs, is to actually come up with a prospective study where we can come up with some guidelines and look at how effective they are. And then eventually do a modeling study where we incorporate both patient preferences for how often they're screened, the balance of the risks and benefits of additional screening for these sorts of things, as well as expediting getting them on the transplant list, as well as what we find from some of these, steps 1 and 2, looking at screening outcomes. And then one other thing I want to bring up, some exciting developments here at the university. In spring of 2023, we are actually launching an HPV clinic. So it's starting kind of slow and we're hoping it's going to grow. But basically, starting in the spring of 2023, any patient who is referred to the gynecologic oncology clinic for management of cervical or lower genital tract dysplasia will come into this one clinic, and we're going to have, basically, it's going to be a wandering clinic. So 1 half day every week between the CSE here at the U and some of the other Fairview clinics that our service, covers. We will basically have a dedicated cervical lower genital tract clinic where we'll evaluate and manage all of these. And so it will be, by experts. We are also in talks with rolling this out across at the West Bank too, where we have our general gynecologist, so that everybody with these conditions will be seen by people who are really dedicated to managing this. We're looking at collaborating with one of our colorectal surgeons who's actually really interested in anal cancer screening. And in fact, one of the other big advances that's happened is recently the Anchor trial results were published. So one thing we didn't know is if you treat precancerous lesions of the anus, do we prevent anal cancer in the same way we can prevent cervix cancer? And so this was a huge randomized controlled trial where some patients with HIV, this is males and female, were treated for their precancerous lesions and some weren't. And what they found is that treating them does decrease cancer risk. So I think what we're going to see in the next couple of years is that there's going to be more guidance on who needs anal Pap tests. And I think one of the most obvious are probably individuals who have vulvar dysplasia, because we know they're at 4 times increased risk of anal cancer. And then because we're seeing an increase in head and neck cancers, we're hoping to eventually involve the ENT and the School of Dentistry as well, because hopefully we'll have some head and neck screening tests available in the near future. We're also looking at, centralizing all this so we can open clinical trials. I think one thing we can do very well is we can treat precancerous changes of the anal genital tract and decrease the risk of getting cancer. But what we don't do really well right now is actually decrease or actually clear their HPV. You can give the HPV vaccine after treatment for precancerous changes. And it does decrease the risk of recurrence by about 60%. So definitely something to consider for somebody who's age eligible, but that's not the optimal vaccine for clearing HPV. So there are some clinical trials looking at alternate ways of clearing HPV. So hopefully we can open some of those trials here. And then we really want to train our residents. You know, we do a lot of the resident training for the entire state of Minnesota. So we want them to have that high quality exposure so that they can then go out to their clinics throughout Minnesota and really provide good patient care. And then the last thing I want to bring up is that for the first time ever, Minnesota is lighting Up Teal for Cervical Cancer Awareness Month. So this was an effort by the local group At Your Cervix, MN, and Lily Taylor in combination with the American Cancer Society. So if you see this, this is one of, I can't remember how many sites. There's a bunch of sites that are lighting Up Teal. If you see this during the month of January, take your picture. If you're on Instagram, tag At Your Cervix Minnesota, because I think one of the things we want to do is continue raising awareness of cervix cancer and HPV associated cancers and prevention. And then this is my contact information. So I can always be emailed. For those of you who are clinicians, if you're in, the mHealth Fairview services and you have a question about a specific patient, the easiest way is actually through Epic InBasket. I check it regularly, and I think it's nice because we don't have to worry about, patient details being shared. And then if you've got specific questions about a specific patient, I can also review their chart. So always feel free to send me a message. So that's what I have for presentation. And I think after Dr. Pratt's presentation, I'd be happy to answer any questions that you might have.
Thank you so much, Dr. Teoh, for highlighting your clinical and research interest in preventing HPV-associated cancers, specifically in the special high-risk populations. So next, we will be hearing from Dr. Rebekah Pratt.
Thanks so much, Naren. What a great presentation, Dr. Teoh. I really enjoyed hearing about the work that you're doing. That's just fantastic. I'll just get my screen shared here. So what I would like to do today is to talk a little bit about a project that I call the Isbar project. Hopefully you can see my slides there okay. Isbar project for short, the long title is Reducing Cervical Cancer Screening Disparities in Somali Patients through a Primary Care-Based HPV Self-Sampling Intervention. So there we go. And just by way of acknowledgement, this is funded by the National Cancer Institute, and it's a large project, which is a team of researchers from Minnesota and a team from Seattle, the University of Washington, including some of the really leading experts on HPV self-sampling. We're really lucky to be working with. We also have a community advisory board consisting primarily of Somali community members and partners helping guide us in this work. So they've been a wonderful contribution too. So despite all of these wonderful things we've just been hearing about, almost half of the cervical cancers diagnosed each year are in the 25% of individuals who are not up to date on screening. And that is a piece of information that's very concerning. And we know that of that number of people who are not up to date for screening, that number is much higher for minority populations. And approximately 14,000 people in the US each year will be diagnosed with cervical cancer. And while many people are diagnosed and treated successfully, over 4,000 people a year still die from cervical cancer. So we know that HPV vaccination and cervical cancer screening are key prevention strategies that have made a really big difference. And yet we're faced with this challenging number that really concerns us about the number of people who are not up to date. So there's a lot of different barriers to screening, and we know that from research that people have done. So it might include people being a little bit afraid of having screening, difficulties with access to screening. There might be kind of issues people have about time and childcare, or just a general reluctance around screening. There's many, many different barriers. Some people feel really embarrassed about having a pelvic exam, or might not have a lot of knowledge about cancer. We know there's many things that can get in the way for people coming to do cervical cancer screening. But we also know that for some populations, there's even more complex barriers. A lot of the work that I do is in partnership with members of the Somali community in Minnesota. And we know that for Somali patients living in the US, they have a much lower rate of cervical cancer screening, and also a lower rate of HPV vaccination, which, as you've heard, is really an important piece of the strategy for reducing our risks around cervical cancer. And also, there's some literature that suggests that women from East African regions have higher rates of cervical cancer. So this is kind of one of these triple threats where we know that it's a high priority group because there's a few things working against them that puts them at higher risk. It's a real priority group in terms of clinical practice, and therefore a priority group in terms of research too. So for the Somali community, we hear about some of those barriers as well. Some of them are the same, some of them are a little bit different. One of the things that we know for people who've come and migrated here or become refugees here is that there may be less awareness about cancer in general, or about cervical cancer specifically, or about HPV. And we even know from some of our previous research that for some Somali patients, the terms HPV and HIV sometimes get mixed up. And if a doctor's having a conversation with a woman about cervical cancer screening and using the word HPV, but maybe she's hearing HIV, they're really in a very different conversation than that doctor thinks they are. So there's lots of things that we can learn and share to improve care. We also know that there's a range of cultural and religious beliefs that can come into play in terms of how people make a decision about undertaking cervical cancer screening, and that patients might have extra particular concerns around modesty in the Somali community. Community members also tell us that they experience some barriers from the health system, that they experience when they are coming along trying to access cervical cancer screening. So for some patients, especially who might be a little bit newer to the US, the system can be seen as overly complex or confusing. People tell us that they feel that the models of care can feel rushed, or that they don't have time for trust building, which might be really important if you're doing a test that feels really new. Or that a clinic might really have a limited amount of ability to share information in the patient's language preference, whether that's through a lack of having information available in a written format or by bilingual staff, and that's been a real challenge. We also find that providers and staff sometimes lack knowledge about some of those common barriers. So again, back to that example around that mix-up around HIV and HPV, if a provider knows that, it can facilitate a different conversation. And so if we can work with providers and staff to change some of those, some of the information they can have better conversations with patients to engage them around the idea of cancer screening. So as you've kind of heard, and I think Dr. Teoh's talk was wonderful because it talks about so many different innovations. But one of the things that is really kind of increasing in this space is the role of HPV screening. So for many years, Pap testing was the primary strategy that was at play for improving cervical cancer screening rates, and it did a really good job. But it hasn't gone far enough. And in some ways, Dr. Teoh and I would like to be put out of work eventually through, being able to make sure we eradicate these cancers before they happen. So now HPV is become to be understood its role in relation to cervical cancer screening. There's a lot more emphasis and interest on screening for HPV, as well as doing Pap tests, or in some cases, primarily doing HPV screening on its own. And so the really interesting thing about HPV sampling is that patients can take that sample for themselves. They can collect their own sample instead of having a pelvic exam. So what that does is it increases the potential to eliminate some of those barriers patients have talked about feeling embarrassed or uncertain. So if somebody's feeling very modest or very worried about having a pelvic exam, they can take a sample for themselves to test for HPV. So that's an emerging strategy that's really exciting. One of the things that we notice is that it's a strategy too that's used in many different parts of the world. So we're seeing an increasing uptake of this as being a primary driving strategy for cervical cancer prevention programs, to make it an option available for patients to be able to take their own HPV sample. It hasn't been picked up terribly commonly in the US at this point. And that's something to we're going to talk about a little bit more, which is a shame, because what we know is that it's got the potential to address some of the barriers that I've already briefly talked about. So I just want to refer to a study here that was done by colleagues at the University of Minnesota really a little while ago now, perhaps back in 2016, this was published. And in this study, we saw Somali patients were mailed home a kit to their houses where they could take their own HPV sample and mail it back to their clinic. And Dr. Kola Okiami and Dr. Rahel Gabre led this study. And they compared women who had that option to patients who had routine screening options available to them in the clinic. And patients who received that mail home kit were 14 times more likely to undertake cervical cancer screening than patients who did not have that option, which is really exciting. That's a huge difference. And so we had this really interesting potential through these emerging modalities to be able to say, how can we put this in the hands of more patients so they can take those samples for themselves and we can start to increase those rates of screening. And saying that, we're calling it an emerging technology. And what did I just say? 2016. So there's questions as a researcher. If we knew this in 2016, why has that innovation not really stuck? If we knew this a few years ago and we know we've got issues and with particular underscreened communities, what are the barriers in place for being able to do this work? And that gives us really interesting and important research questions to explore. So I want to talk a little bit about the Isbar Study, which is the study that I'm very immersed in at the moment. And the study has three main components. And first off, we wanted to answer a little bit of that question. If we know that this is impactful, and we know it can make a difference, and we know that this is a community that needs this innovation, why isn't it being done? And so the first step of the study was to work with people providing care in clinics, providers and staff, and to actually do focus groups with Somali patients themselves and say, if this was an option, would you access it? Or if this was an option, how would you provide this in your clinic environment? To really spend some time trying to understand, why haven't we done this before? And if we do go ahead and do it, what is it that'll make it possible to do it? What is it that'll make it straightforward to provide this type of work? And then the second part of this study is to go ahead and offer HPV self-sampling in 3 primary care clinics to all patients and assess the impact of that option on cervical cancer screening uptake after 12 months. And then finally, what we will do is we'll come back to those clinicians and patients and say, hey, how did that go for you? What are the ways in which this worked well or this didn't work well in terms of this type of approach? So we can learn from these innovators about if this makes good sense to share with other communities. And I'm going to talk a little bit about what we've learned so far. So we spent a good amount of time interviewing clinical providers and staff, and overall they were very, very interested and supportive of using HPV self-sampling in their practice, and they were interested for all patients. What they told us was that the barriers we were coming to them with in terms of the barriers facing Somali patients, they felt a lot of other patients experienced too, whether it was gender diverse patients, patients with disabilities, patients with trauma. They gave us a whole laundry list of patients they felt could benefit from this being an option to increase cervical cancer screening rates. They saw HPV self-sampling as being easy to do, easy to integrate, and something that they could integrate into their practice, no problem. But one of the things that we did learn is they knew very little about it. There's many, many studies that show that when a patient takes their own HPV sample, it's an excellent quality sample, and it's providing excellent information that is doing a high quality cervical cancer screen. And even our primary care providers we talked to often had very little information about that. So it showed us there's a very big need to educate our providers about these modalities that are emerging if we're going to see any uptake in our health system. And they talked a little bit about the need to keep focused on the needs of people who might be particularly underscreened, such as, do we need to tailor information materials, or how can we help support patients who've been the most reluctant to engage in screening? We also conducted focus groups with Somali women about HPV self-sampling, really spending time with them saying, here's this option. What do you think of that? What would it take for you to do this? And is there anything we need to learn? And what women told us is that for many of them, they had experienced difficult circumstances of cervical cancer screening in the past, where some patients told us that they felt that they had even been coerced into screening, or they had done the screening test, but they never knew what it was for. So again, we've got providers, they might see a patient has had a cervical cancer screening test in the past and assume that they know what that's about. And that would not be the right place to start. It's good to assume that patients need that reinforcement about what it is, and to work with patients in a way that really is gentle about the fact that for some people it's been a tough experience. We also found that there's knowledge gaps that need to be addressed, mostly around cervical cancer in general and cancer and preventative approaches and screening for all cancers. But there was a lot of interest and support amongst the patients we talked to about doing HPV self-sampling. And that there's, opportunity to work with the people who took part in our focus groups and our community advisory board to tailor or create instructions and guides that were visually attractive, appealed to people who were Somali language speakers, culturally diverse materials, and saying that they helped us come up with creating a video of instructions that's really wonderful, that we'll have available for our partners in Somali audio file too. So we're in the implementation phase. What was really lovely about this project is we started out with a focus primarily on Somali patients, and we went to our clinic partners. They said, we love this project, but we want to do it for everyone. We're so committed to this. So on February 20th, that's right, just in a month, we'll be starting at these 3 clinics, People Centre, the Community University Healthcare Clinic and Smiley's Clinic. Will hit go on offering HPV self-sampling as part of their usual care for cervical cancer screening. And I'm really proud of all of these clinical partners, because their innovation, their preparedness to say, let's do it for everyone, means they'll be the first 3 clinics in the US to implement this in usual care. So they're excited and ready to go. We're excited and ready to go too. And training is underway. And those trainings are both covering, the thing where we started. What does it mean to care for Somali patients in particular? And also, how do we think about HPV self-sampling and how they do that in their routine practice? So in terms of our next steps, we've had to adapt our study for the clinic-wide implementation, and then we'll keep integrating all the things we've learned as we go. And as we work with those clinics for implementation, we'll come back to them at the end and say, you are cutting-edge innovators. How can we learn from the advancements that you have made in offering this for the first time in the US? So we can share their experience of implementation with other clinics. So we can start to get over that gap between having that research evidence and starting to see that impact in clinical practice. So that's my last slide. I see I'm just a little tiny bit over time, but if you want to get in touch more about the study, I didn't put my email there, but indeed get in touch with us. I'm pretty easy to find, and I'll be happy to answer any further questions or share more information.
Wonderful. Thank you so much, Dr. Pratt, for, highlighting the cervical cancer disparities and barriers to screening among Somali American women, and then also just the work that you're doing to reduce these disparities with the HPV self-sampling. So thank you so much for sharing. So we will transition to now our Q&A. And so in true Fireside Chat fashion, we have to share our fire. So let me get our fire going. So do you all see my fireplace? Okay, Perfect. So we've had quite a few questions submitted already. And then I saw a few that were submitted through the chat. There's one that I think Dr. Teoh, you might want to probably answer that. If you could actually just type in your answer, I think it might not be applicable to most of our audience. So if you want to answer that question and type it, and then anyone who is a clinician or is involved in more research, feel free to read Dr. Teoh's answer to that question. So we'll just kick it off. Dr. Pratt, I actually have a question for you just right off the bat, so I'll go ahead and ask you. So can lack of HPV vaccination in a community such as the Somali community, as you've highlighted, be considered a public health issue? And if so, how can we increase the awareness?
Yeah, thank you for that question. I absolutely agree that is a public health issue. And many of my Somali community partners are very quick to tell me that actually, as a group in the community, they used to be very, very highly vaccinated for all things. And, you know, through a range of events, including a very vigorous targeting of the community through anti-vax lobbies, those rates have really dropped. And so there's a lot of work to do to improve vaccination rates as well. And we've been doing some research around that. And what we find is when we come to the community in that spirit of, here's this public health issue, and start a dialogue, we can really make a difference. So I would endorse that idea that we need to think about it as a public health issue.
Great, thank you for answering that. And then another question here. Okay, Dr. Teoh, I do see you're typing, so we'll hold off on asking you this question. So does typically with, so can you talk a little bit more about just HPV in general? How is it contracted? And Dr. Pratt, if you can kind of touch on that while Dr. Teoh is typing in that question. So how can you contract HPV and why is it important that we vaccinate against it?
I think the really important thing to know is that it's an incredibly common infection. And so up to 90% of people in their lifetime may have an HPV infection. It is associated with higher risk of HPV is associated with having a kind of a higher number of sexual partners. But I think it's a misstep for us to think about it entirely in those terms because it's an incredibly common and transmissible virus that many people will have and never know they have. And so in some ways, I think thinking about in a very liberal way and thinking there could be a number of ways to get it we haven't really focused on in terms of close physical contact between people as well. So I think there's not many conditions in this world that we would say 90% of people might get this infection that we just are like, great. Who cares why, who cares how, let's just get that vaccination out there is my general feeling. I think some people get a little bit hung up on the things that are risks for getting exposed to the infection, but it's so incredibly common that there's such a wonderful opportunity for reducing it if we do focus really hard on that blanket vaccination coverage. And that is not just at that adolescent age, that's ideal, but you can have vaccination for HPV in this country now up to the age of 45. So there's a good opportunity to take that step of protection.
Great, thank you. And Dr. Teoh, then I will ask you, at what age should screening begin for cervical cancer?
Yeah, so there are different guidelines for cervical cancer screening. So depending on which guidelines you look at, it's either 21 or 25. 21, the organizations that are recommending starting at age 21 are actually recommending Pap testing alone between ages of 21 to 29. And the American Cancer Society, which is recommending starting at 25, is actually recommending starting with the HPV test at age 25. So I would say by 25, the latest. I think 21 to 25 is really a discussion. I think that, definitely at one of those ages or somewhere in between, you definitely want to start. And that is regardless of whether somebody is vaccinated. So even if somebody has received the HPV vaccine, they should still be screened for cancer.
And on that note, so if you have had a positive HPV Pap smear in the past, but have since been cleared, are you still at high risk for developing potentially cervical cancer?
So the risk is definitely lower. We know that the people who are at the highest risk are those who have persistent HPV positive testing, and specifically if it's the same strain. Those are the people at the highest risk of cancer. Now, there are going to be a lot of people who have it sometimes and don't have it other times, and so those patients are going to be at much lower risk. But I think that one of the things that's important is that even if you had a completely negative test, that you need to continue testing. It's not that you had that one negative test and you can stop there and be reassured, because HPV can, you can suppress it at different levels throughout your lifetime.
And then Dr. Teoh, another question based on a question that just came through the chat. So what are you doing for older adults, or if you can speak on this a little bit, what is being done for older adults who have been diagnosed with vulvar cancer?
So we actually see a lot of vulvar cancer in Minnesota. And so I think, when we have cancers that are limited to the vulva and resectable, surgery is usually the first step. There are some we use chemoradiation for, or some patients we just do chemotherapy for. So really just, there's a lot of variables that go into it. It depends on, the state of the tumor at the time that they're diagnosed. And the other thing is that I think the question specifically asked about older adults is it also depends on their, goals of care and their other comorbidities. So we have older patients. We actually routinely see patients in their 80s and 90s now who are unfortunately diagnosed with cancer. And sometimes those are our healthiest patients. There's a reason that they're getting into their 80s and 90s. And we've got patients who are that old or younger who have a lot of other health problems, and it's going to be harder to tolerate treatment, or potentially their lifespan is not going to be that long because of other factors. So we have some general guidelines for treatment. If you were to Google it, or the National Comprehensive Cancer Network has general guidelines for if you have this stage cancer, this is what you do. But at the end of the day, for every patient, we have to individualize treatment depending on their particular tumor, their health status, and their goals of care.
Thank you. And then I guess for both Dr. Teoh and Dr. Pratt, if you can maybe touch on this a little bit. So with just some of the hesitancy that we've seen with the COVID-19 vaccine, do you feel like that has interfered in uptake of vaccination for HPV?
That's a good question. I think that the period of time with COVID-19's had an impact on a range of different things. And I think we're still learning how it has had an impact on things like cervical cancer screening uptake, and how much of an impact are we having on HPV vaccination. So unfortunately, I'm hearing people say they're concerned that people put off vaccinations and they've put off screenings during that time, and that we're now seeing a little bump in some later stage health conditions that maybe could have been caught earlier. So I think we're in a period of time of learning about what the impact has been. I would hope some of the lessons we've learned about how to engage communities around COVID vaccination might be really great to help us think about that same kind of messaging we could use around HPV vaccination. And often that's about having really great community partners and trusted messengers and listening. Often we heard with the COVID vaccine, sometimes people weren't necessarily declining, but just needed more dialogue and more conversation and more time. And so that's a good lesson for us to keep in conversation and keep in dialogue about that no matter what.
Thank you, Dr. Pratt. Dr. Teoh, do you have anything to add?
No, I think that, I agree with everything Dr. Pratt said. I think in general, we saw HPV vaccination coverage drop by 70% during the pandemic. I think these initial numbers we think are just because people were not going in, so for a while we were told to shelter in place. I know a lot of people have tried to get clinic visits, and because of decreased staffing, having to, decrease the number of people in the waiting room, it was harder to get an appointment. So even for those, parents, guardians, individuals who wanted to be vaccinated, it was more difficult to get an appointment. So we think that the initial 70% drop is probably due more to lack of access than anything else. But I think, Dr. Pratt's right. We're going to find out, now that we're kind of learning how to deal with COVID, what some of these other concerns are, because I think, we might find that now that other vaccine concerns have been brought up, whether they're, based in fact or not, we're going to start hearing about that. And I agree, it's a great opportunity to engage in that dialogue. And I do want to point out that they have looked at, administering both the HPV and the COVID vaccine at the same time, and that is safe. And so that is something, if you're seeing somebody in the clinic or you need to catch up on your vaccines, that to decrease the number of visits, you can get both vaccines at the same time.
Great. Thank you so much for addressing that. That actually was a question that came through the registration. So let's see here. What else has come through? Okay. How often, and Dr. Teoh, this is going to be a question for you. How often should you have a pap smear after the age of 65?
So in general, the guidelines say that after 65, if you've had adequate screening, that you can exit. And that assumes that somebody is at average risk, right? So somebody who has a higher risk, the solid organ transplant recipients, people who are on immunosuppressive medications, they should continue lifelong cervical cancer screening. Those who have had previous precancerous changes of the cervix, even if they've been treated, need to continue screening. And I think one of the keys is, as far as exiting as well, is what was your screening history beforehand? So right now, the guidelines would state that you have to have 3 normal pap tests within 10 years before age 65, or 2 negative HPV tests within 10 years. And so I think a lot of times we're seeing people exit who haven't met those criteria. So although we're saying, oh, you're 67, you don't need screening, these people actually haven't had screening for decades. Their last screening was when they had their last baby in their 20s or 30s. I do think that having those negative HPV tests are probably more important than that pap test. And I will say the guidelines came out before we were always doing routine HPV testing. But I think for those patients who have had, consecutive negative HPV tests before 65, it's probably safe to exit. I think, the negative pap, if they've not had an HPV, it's probably safe for most people, but there's probably still a little bit of risk. And then there is some discussion to be had, with your healthcare provider. But I think it's really making sure that and if you're unsure of your screening history before 65, to make that known as well. Because again, I think the biggest risk is those people that we are exiting from screening who really have not had adequate screening prior to 65. So we don't really know that they, meet the low risk criteria.
Thank you, Dr. Teoh. Okay. I know, Dr. Teoh, you mentioned one organization, but are there any local organizations for those who are diagnosed with cervical cancers, or their support organizations, and just any organizations that share information about the importance of being aware about cervical cancer and the HPV vaccine?
Yeah, so At Your Cervix, Minnesota. So it's you can find them on Instagram. They've got a website. It's actually a local group, and that was started by a survivor who was in her 20s when she was diagnosed, and basically got through all of her treatment and just felt like nobody talked about her cancer, and that she didn't know anybody else with this cancer. And unfortunately, we can't connect our patients. We can't share patient information from one to the other. So she actually started this group. Unfortunately, it was started right before the pandemic. So she was all excited, and it was off to a little bit of a slow start because everything shut down, but definitely picking up steam. I give that, Instagram handle and website to all of my patients, because it is a really vibrant group of people who have had cervix cancer, who can support one another. They're doing a lot for advocacy for HPV vaccination, for getting screened, because they don't want anybody to have that cancer. At the national level, Survivor, so CERVIVOR is the national organization, very similar. In fact, the leader of At Your Cervix MN did training with Survivor for, how to get a group like this off the ground. So I highly recommend it, because I do think a lot of people, for all the reasons that Dr. Pratt talked about, because HPV is associated with sexual contact of some sort, although like she said, we're not sure what level of contact you even need to get the virus. So there is some shame, unfortunately, associated with that, which should not be, but I think then people feel afraid to share it. They feel alone. So definitely connecting with one of these groups, I think, is a huge help. And I've seen them interact, and I've talked with them, and they're just a great group who are there to support anybody with a diagnosis, and even pre-cancer, so I think that those are the other people who feel like nobody talks about this. I can't tell anybody, and they will support individuals who are going through pre-cancerous treatment as well.
Great. Thank you for sharing those. Dr. Pratt, do you know of any organizations that you'd like to share?
Oh, I would go with Dr. Teoh's recommendations on that for sure. I think that's great to connect with other people. There's also survivorship conferences that are organized through ourselves at Masonic Cancer Center. So there's a lot of organizations out there. So it's a great thing. I'm a cancer survivor myself. I think connecting with people and taking that time to connect with others that have had your experience is a great thing to do. So check them out.
Thank you for that. And we unfortunately are out of time, so we're going to have to end it here. But I think a really key takeaway is that cervical cancer is preventable and HPV associated cancers are as well. And so just spread awareness about these cancers and kind of check out some of these local organizations that are doing such incredible work. And so we will have to leave it here. Thank you so much, Dr. Pratt, Dr. Teoh, for being here with us today and again, helping us spread awareness about cervical cancer and just all the incredible work that you both are doing to eliminate some of these HPV associated cancers. So you will all receive an email shortly following today's program with a link to complete a very brief survey. We would really appreciate if you could just spend the moments to complete the survey to share your thoughts and feedback. We do use this information to plan our future fireside chats. And after completing the survey, you can enter to win a prize pack filled with goodies from the Masonic Cancer Center. And then the Amazon e-gift cards will be mailed out to all live attendees that are not University of Minnesota affiliated in the next few days. And then join us next month for our fireside chat on Wednesday, February 22nd from 12 to 1 p.m. Central Time to honor Henrietta Lacks in recognition of Black History Month. So we will be joined by Dr. Maya Robertson, and she's an associate professor of health policy at Vanderbilt University School of Medicine. So mark your calendar because you do not want to miss that one. And then just be sure to follow the Masonic Cancer Center on all of our social media platforms to stay up to date on our future announcements and all of the events that we, the Office of Community Outreach and Engagement, host. Thanks again, everyone, for joining us, and hope you all have a wonderful rest of your day. And a special thank you to Dr. Pratt and Dr. Teoh for being here with us today. Take care.